Good morning. This is a speaker check for Marcy. Marcy, are you with us on the line? Good morning. This is a speaker check for Marcy. Marcy, are you with us on the line?
Yes, good morning.
Very good. Good morning. Thanks for being here. Sounds like we can hear you well through the audio. Are you able to see the readmissions and care transitions title slide on your screen?
I am, thank you.
Very good. Marcy, are you able to see the slide advance?
Yes, I am. Housekeeping items right now. Yep.
Very good. Thank you. Marcy, we have about 9 minutes till we begin the session today. We have just one more speaker sound check to do. At this time, if you are ready, you can mute your phone line and then just unmute it manually when it's your turn to speak.
Perfect. I will do that now. Thank you.
Thank you.
Appointment on Thursday, and after this.
Hello.
At this facility, are they allowed to go out for?
Morning. Is this Jane?
Yes, it is.
Appointments and come back to
Good morning, Jane. Thank you so much for joining us.
Thinking he
At this time, we're going to do a sound check for Jane. Jane, it sounds like we're able to hear you well through the audio. Are you able to hear us as well?
Yes, just fine.
Excellent. And on your screen, are you able to see the readmissions and care transitions community of practice slide?
Yes, I am.
Jane, are you able to see the slide advance?
Yes, I am.
Excellent. Thank you so much for joining us. At this time, you can place your line on mute and then manually unmute when it's your turn to speak.
Okay, sounds good.
Thank you, Jane.
I remember thinking we should have been there.
Good morning, everyone. Welcome to the Readmissions and Care Transitions Community of Practice. We have just about 5 or 6 minutes till we begin, so thanks for joining us. Please do place your phone lines on mute so we don't hear your background noise. Again, we'll be starting in about 5 minutes. Good morning and thanks for joining us. We'd like to ask that as you join, you please place your phone lines on mute. We'll be beginning in about 2 minutes. Good morning, Compass Hen, and welcome to the October 24th Readmissions and Care Transitions Community of Practice. We are so thrilled that you've joined us this morning. This is Kate Carpenter with the Compass Hen team. We have just a few brief reminders and housekeeping items as we get started this morning. We'd love for you to navigate to the chat box and let us know who's in the room with us today. If you could just give us your name and your facility. And then there's one more thing that we'd like for you to share in the chat this morning, and that's to let us know if your facility is currently using any sort of telemed services currently, yes or no. And if you are typing yes, if you wouldn't mind sharing with us where you're using it, if it's in the ED or the ICU with your cardiac patients or in a specialty clinic. If you wouldn't mind including that with your yes, we'd love to see your input. Also, a reminder as you join us, and there'll be several more, I'm sure, joining in the next few minutes, we would ask that you do mute your phone lines. This kind of helps us cut down on the background noise as we pass the mic to speakers today. If you could avoid placing the call on hold, that would also prevent us from hearing your background music during today's presentation. A reminder that these sessions are recorded and transcribed, so if you're unable, just 1 second. We're hearing someone's background noise, just 1 minute.
Your participant ID followed by pound. Otherwise, just press pound. You are in the Zoom meeting now. There are over 20 participants in the meeting.
If you would please, those that just joined, could you please mute your line? Thank you. So again, a reminder that this session will be recorded and transcribed and will be posted in the Innovation Library for future reference. We do encourage your questions and discussions throughout today's session for our speakers. You can submit those one of two ways. You can type them into the chat box throughout today's presentation, and those will be moderated during the Q&A session at the end of the hour. or when the time comes, you may unmute your line and go ahead and speak the question into your phone. With that, we're going to move to today's content. The objectives for today are to define telehealth, describe the spectrum of telehealth services, share some of the recent telehealth legislation and regulations, share some of the benefits to rural hospitals and how telehealth is improving quality and outcomes, share some trends, and lastly, we have a couple hospitals joining us today to share some of their stories with telehealth. With that, it's my pleasure to introduce today's speaker, Mandy Bell. Mandy is Quality and Innovation Officer for Avera eCare. She oversees the creation of new eCare service lines and facilitates innovation, business development, public policy, and education while overseeing quality, compliance, and research programming. She has comprehensive experience managing the business operations related to telemedicine applications and was instrumental in the development of Avera eCare's school health program. Mandy has a BA from Augustana University in Sioux Falls, South Dakota, and a master's in healthcare administration from the University of Minnesota. Mandy, thanks so much for being here. The floor is yours.
All right. Well, thank you for that introduction. It's a little intimidating to have someone read your bio back to you, but I'm really excited to be here today. I've been working in the field of telemedicine for almost 10 years now, and part of the Avera telemedicine network and their development during that time. So telemedicine is one of my passions, and I'm very excited to share it all with you today. So maybe to get started, we can talk a little bit about Avera's experience as a rural health system and some of the challenges that we face in working with our own hospitals and clinics every day that led us down the telemedicine journey. So if you could go next slide. So within Avera, we've got about 30 some hospitals. Most of those are critical access facilities, as well as dozens of clinics across South Dakota, Iowa, Nebraska, and into Minnesota as well. And the theme that those hospitals share is really how do they continue to provide really high quality services to their communities despite the challenges that they're facing. And when we look at our facilities, many of them are in communities where the population is actually declining or aging. The younger population is not moving into town, and so as folks are retiring, who's going to take care of them as they age in place? What workforce are we able to recruit as far as nurses, pharmacists, physicians, and nurse practitioners into the community to continue that practice long into the future? When we talk with our providers and our hospital administrators, some of the challenges that we hear are that physicians are nervous to come into a rural practice, especially if they haven't had that practice style before, because they're concerned about being the only provider in town on the weekend. They know they've got to be the one covering the emergency room, the hospital, perhaps the clinic, and the long-term care facility as well. And they know that something could come up someday that they don't feel prepared to deal with. And that feeling of being all alone when everyone's looking to you for help is very overwhelming. So they struggle with how do they get people to try on a rural practice. Maybe it's that new nurse coming out of school and working the overnight shift. How to make them feel confident in filling their roles in that facility so that they want to stay in the community and continue to practice. At the same time, we hear from our administrators, they're facing tough economic situations. Again, sometimes they're seeing their volumes decline as services move out of town. They're faced with the same pressures that you all know with declining Medicare reimbursement from the critical access standpoint, as well as lots of pressures from insurance and other new risk-based models and how they provide care cost effectively. And at the same time, they're trying to keep up, right? How do you bring in the latest and greatest CT or mammography to your community so that they feel confident that they're getting the state-of-the-art technology within their community and they don't have to travel for care. And the same goes for quality. They want to compete with the hospital just like everyone does. Yet they have less resources and they have a little bit, people that have to wear many, many hats in providing all these services. So we feel telemedicine can make a role in addressing all these challenges to some extent. Next slide. So when we look at the promise of telemedicine within Avera, it's really been with that lens of how do we support our own hospitals and clinics and the providers that work there in providing the best care possible. We know that in these communities, there's often challenges with how do you access specialty services. The specialist might come to town once a month or once a week, and it's not there as often as the community would like. Maybe in a inpatient side, the provider's not in the facility overnight. They're on call at home and they're just minutes away. But that barrier of how the nurse gets a question answered in the middle of the night can be a challenge. So can a telemedicine network really ensure that you have timely access to the right specialist for every patient every time? And we really think it can. The same with quality and outcomes. We feel like telemedicine, when it's there 24/7, 365 in the background, available to watch patients, available to answer questions from the nursing staff or the provider staff, can ensure that the access to the evidence base is right at the fingertips of our providers whenever they need it, and that the care can be implemented that much faster, leading to better patient outcomes. And we'll give some examples of that as we go throughout the presentation today. The same with the cost of care. So we know that often our patients are going from one setting of care to the next and to the next, and getting duplications of tests, maybe unnecessarily driving by the community hospital to go to a more urban setting to get tests, when we know the cost of care is probably most cost effective within the local community. Can telemedicine bring services to that center in a very cost effective way of making cardiologists available all week, but maybe only to see a handful of patients? And we think it can, to keep the economics within the facility. And finally, to that workforce piece, can we give our specialists and give our family practice providers and nurses access to peers, so that in the middle of the night or in the emergency room during that really difficult case, they've got a group of peers that they can quickly reach out to and feel like they've got some support with. And we think it can do that as well. Next slide. If you look at telemedicine, though, it's really not a new concept, yet it seems like it's taken a long time for it to take off. I was surprised to learn that NASA was actually getting credit as the founder of telemedicine back in the 1960s as part of their space program. And quickly thereafter, you see that academia took up telemedicine as a way to provide psychiatry at a distance, and found that it could be an effective way to bring psychiatrists maybe into a prison setting, for example. The U.S. military adopted it in the 80s, and we even had the American Telemedicine Association being founded in the 90s. But it's not until almost 2 decades later that we see some real advancements in the field. And on this slide, they're pointing out one company that did its 1 millionth virtual visit. And I'll tell you that I think about 90 to 95% of those virtual visits actually took place on the phone and not over video conferencing technology. But a long time there in between before we really see it to take off. Same with Kaiser. They're now saying that they do about half of their healthcare out on the West Coast virtually. But again, when you look at their numbers, a lot of that's like an email, a patient portal, link between the patient and their provider, or a provider-to-provider consultation that's taking place more like a secure email than the video encounter. So telemedicine's got a long hill to climb. Next slide. In the early 2000s, Congress actually passed legislation to begin to reimburse telemedicine. So over 17 years ago, Medicare began reimbursing for telemedicine at the same rate that it does for other inpatient care. But there were concerns at the time that this form of technology and this way of delivering care would be so popular that it'd be terribly costly to Medicare and to other payers. So Congress quickly constrained what they were going to pay for when it came to telemedicine, and we'll talk about that in a little bit. But they limited it to rural areas. They limited it to a specific set of codes and a specific process for adding new codes. So when they rated the legislation in 2000, they thought it would cost Medicare about $150 million in the first 5 years. And you can see from this chart here, we really haven't seen that much growth in telemedicine charges during that time. In fact, we still haven't met the $150 million mark for Medicare expenditures. Next slide. But on the other hand, it is finally taking off. So this is that same set of numbers, but charted. You can see that kind of hockey stick growth, if you will, where we've really hit the growth curve on what is being reimbursed by Medicare for telemedicine services. And a couple numbers, in 2014, you see it was about 14 million in claims that was paid back to providers for their telemedicine services, representing over 100,000 different types of services by 55 specialties. Now, again, I would say most of this, 4 million was probably paid on behavioral health type claims, but you can see that clear growth where it's being accepted by more and more specialties and clinics and locations. Next slide. So what is telehealth if we take a step back? You can do next slide. There's really a whole spectrum of services that fits under the telehealth umbrella. When you look at the definition, it's really any kind of care that's facilitated at a distance via technology. So you can see in our early examples, some people include the phone care as telehealth. I don't know that I would count that, but that can be a form of telehealth. Maybe you could go as far as say faxes and EMRs or telehealth. So that would be almost everything we do today. But really, when I look at telehealth, I look at this particular spectrum of services, kind of from the left being kind of the more straightforward or simple types of technologies to the very complex on the right. And on the top, we've got those that are more on the provider to provider side. So a physician may be reaching out to another physician versus ones on the bottom, which are more patient to provider. And I'll walk through these just really quickly to give you a little taste of the broad spectrum that's included under the telehealth definition. The first one, e-consult, we've talked about a little bit. That might be secure, kind of structured message from a primary care physician to a specialist. They would type up a patient referral note, send it off, and wait a couple days to hear back from the specialist to see if they can get their questions answered. And that's been used very effectively within health systems as a way to deal with their complement of patients. We also seen this newer, well, it's not so new, but it's a very effective model called Project Echo take off. And that comes out of New Mexico. It's a learning collaborative approach where, at a designated time, once a week or once a month, a group of primary care physicians gets on a video call with a specialty panel, and they talk about very specific types of treatment. For example, hepatitis C with an infectious disease physician. And the ID doc will spend the first part of the call maybe providing some didactic education to the group, but most of it's with the primary care providers actually presenting cases to the panel and getting some assistance with a treatment plan for those trickier case presentations. And they get to hear the recommendations from the experts as well as the other primary care practices that are on that call. And so as a group, they're learning on how to address hepatitis C effectively. And the studies coming out of these are really remarkable, showing that they're very effective in how they are treating these diseases, and the patients are having similar outcomes to being treated by the specialists themselves. So a good way to be cost effective, maybe reduce the amount of time it takes to get to a specialist. I am going to provide a link to Project Echo. It's a nonprofit organization, and they definitely make their resources available to others that are interested in the program. Outside of Echo, we see curbside consults occurring. Maybe a provider brings secure video into the patient bedside and chats with, the hospital maybe chats with an endocrinologist to deal with the patient on the inpatient side. They could do that on the outpatient perspective as well. So the primary care provider is really there with the patient presenting the case. Acute care, you're probably well familiar with models like telestroke, where it's really about that quick on-demand connection with the neurologist and the ER to get the patient treated for things like stroke. We've seen it for burn and general emergency medicine, psychiatry, lots of different specialties now offering that 24/7 opportunity to connect from the emergency room. And finally, EICU, more of that ongoing monitoring of patients when they're in intensive care. So the telemedicine in this case is pretty advanced, and then it's combing through the medical record of that patient, looking at their vital signs, looking at their ventilator settings, and showing our remote hub of providers exactly what's going on with that patient. And all of that data then can be analyzed and proactively alert the care team at the hub that there's a slight change in that patient's status, maybe their heart rate's elevating, maybe a lab value came back that's concerning, so that they can video into the room and start to make interventions if needed. On the patient side, we see the same kind of progression. Today, you might have patients that log into your patient portal and do an e-visit. So they send their doctor a quick note and expect to get an answer within a couple of days. They might even take a picture of a rash or maybe an incision site and want to get an opinion from their doctor if everything looks okay. There's also virtual visits, a similar idea where they can log into a portal or a website and real-time chat with their provider over a webcam or over their phone and get their urgent care illness taken care of. Kind of the next level would be going into the clinic and having somebody like a nurse or an MA walk them through the exam with the specialist. So you might use stethoscopes in this case that can transmit that information to the specialist, or special otoscopes or exam cams to get a good look at what's going on with that patient. In those cases, they often have access then to electronic medical record, labs and imaging, so they can do a full exam, but just remotely. Remote patient monitoring is probably of most interest to this group, and we're seeing that field really take off, where devices are placed in the patient's home, maybe a scale or a glucometer up to a blood pressure cuff, peak flow monitors, O2, pulse oximeters. We've seen some really exciting things coming out with maybe like white blood cell counts or INR labs that can be done at the patient bedside. And I think we'll continue to see this remote patient monitoring field grow, allowing nurses or other providers to remotely watch their patients and the labs and daily weights and things that they're entering in, and call in and check in with the patient if they're seeing something concerning. And the last one here is kind of maybe a joke. I don't know that I've seen a lot of telerobotic programs out there, but it's possible. I think they've been able to show that somebody could remotely operate a surgical robot, although we don't see much of that today. We are seeing that folks are bringing specialists and trainers into the OR via camera remotely to help coach on really difficult procedures. So I think we'll continue to see this field advance and the spectrum grow with advances in technology, but you can see today it covers everything kind of from soup to nuts, so to speak. So next slide. What's most important when we think about telemedicine is probably how Medicare defines it. So here we've got definitions from the American Telemedicine Association and the Advisory Board. You can see they're covering things like that, real-time video visits, as well as remote patient monitoring, and maybe even the photos of the rash as an asynchronous going forward. But really, if you click one more time for me, Kate, what we're looking at from a Medicare perspective is that they only are dealing with the real-time video consults. So Medicare is really, again, since 2000, defined in a very limited fashion what telemedicine is. They limit it to specifically rural areas. They limit the types of healthcare providers that can administer these services, mostly to physicians and behavioral health providers. And then they also limit where the patient's located, what type of facility they're located in when they get the services in order to receive reimbursement. So typically a clinic or a hospital or a skilled nursing facility or something like that. Notably, it's not their home or something like a home, like an assisted living facility. So it's pretty constrained from that perspective. Next slide. Outside of Medicare, we also see lots of variability in how states look at telemedicine and how they reimburse, both from a Medicaid perspective, as well as if they are they have telemedicine payment parity, which requires commercial insurers to pay for telemedicine. When we look at Medicaid and commercial insurers, most of them are following somewhat what Medicare does, although not all of them are as restrictive as what Medicare does. Also with the states, there's lots of different regulatory differences between the states, what providers are licensed and eligible to practice. If the medical board requires patient-informed consent, or if there has to be a nurse or another telepresenter at the patient side when the case is occurring, what they can prescribe. All of these vary by state quite a bit and can be a little bit complicated. So I'm going to paste into the chat box another link to a great resource, the Center for Connected Health Policy, which has a state-by-state manual where they really look into this every year and give it an update for what's going on within your particular state. Next slide. One of the changes that we're seeing, what are the changes that we're seeing in telemedicine? There's been quite a bit of advancements in technology. When we first started, it was pretty expensive and worked about 90% of the time. Today, it's becoming quite affordable for most people and working more like 99% of the time. So something that folks are more willing to invest in. There's lots of changes happening in legislation. You're seeing legislators jump on board and want to support telemedicine. And I think we'll go through some of the changes here in a minute, but lots of exciting movement even happening at the national level, the federal level. Incentives are changing, and I think this group probably knows that better than I do, but instead of paying for volume, we're trying to pay for value. And so we think of things like readmissions, ACOs, bundled payments. It's really changing the equation on, I might not get reimbursed for this telemedicine service, but it might be worth it for other reasons. We're also seeing health systems adopt it because of consumerism, wanting convenience. Our patients want convenience, and some of them really want that really fixed price healthcare that they can get on their computer at $49 rather than going into the clinic and kind of having an unknown cost when they're in that high deductible health plan. And all in all, we're just seeing more acceptance. Folks are using Skype and FaceTime, maybe not on a daily basis, but they're very comfortable with it. So adapting it to their work style or to their healthcare makes a lot of sense. Next slide. So we're going to talk a little bit about current legislation and some of the regulations to look out for. Next slide. There's been quite a bit of movement on legislation this year in 2007 alone. Some of the trends have been around moving that reimbursement from just rural communities to urban facilities as well, looking at giving more opportunities for ACOs and Medicare Advantage plans to adopt telemedicine if they want to and pay for it in the way they'd like to. The Chronic Care Act, there's that gray box on the side, those are current bills before Congress. And the last one, the Chronic Care Act, was recently passed by the Senate and has been introduced in various forms in the House as well. And that one looks specifically at telestroke networks and providing that service within more urban areas, as well as home dialysis opportunities and some of the Medicare Advantage and ACO opportunities as well. So it's good to see that these bills are not only being introduced, but actually passed and hopefully will go into law maybe this year, if we're lucky, or in the coming years. We've also seen quite a bit of changes on the state level as well. 29 states have adopted payment parity. I think I have a map on that in the next slide. We've also seen many states adopt the Interstate Medical Licensure Compact, which is an evolving group of states and who's adopted that. And I will paste that link in. That'll be my last link to paste in. But there's a map available there to see if your state's participating in that compact, which allows all physicians, but particularly telemedicine physicians, to more quickly get licensed within states if they have good standing within their home state. And then probably a little bit further back, we're seeing many states take up the practice of telemedicine at the board level. So the board was passing specific practice requirements. We've seen that in Iowa in particular, requiring things like patient consent and access to the remote practitioner's education and emergency plans, things like that. So lots of good changes happening in the field. Next slide. And this is going to be a quick map to show parity legislation that's been enacted in the states. You can see our part of the world is not as well covered as you might expect, but I think that's because some of our states and the peers within them had embraced telehealth a while ago, and so there's less pressure. And maybe it's just that they're not hearing from their constituents this is important. So good momentum on the national arena as a whole, and we're watching those states very closely and seeing how that's impacted their uptake of telemedicine. Next slide. Finally, some regulatory issues I just want to make everyone aware of. Telemedicine is not unlike regular medicine, and so things like ensuring the providers are appropriately credentialed to provide services has been an important piece of what we do here. So not only licensed in the state, but credentialed at the hospitals and the provider-based clinics in which they're providing services. recognizing that the providers are responsible for HIPAA and high tech like they always are, but that really choosing the right technology and vendor is crucial to protect patient privacy. Understanding how electronic medical records fit into the provision of telemedicine. In particular, how we coordinate care from a distance back with that patient's home clinic, make sure they've got access to their medical records even after the encounter. Things like patient consent vary by state. Do you need it in order to host your telemedicine encounter? Can you establish a patient-physician relationship simply over the video camera, or do you have to have a face-to-face appointment before you ever practice telemedicine? Also being aware of prescribing laws, especially around controlled substances, and can you prescribe with just a video encounter? And finally, as you're setting up networks, you run into questions around anti-kickback, STARC, and fraud and abuse that are really important to look at as you're setting out on your telehealth network. So next slide. We're going to steer away from the regulatory issues and do a little bit of the business case. I'm going to go through this a little bit quickly because I'm a little slower than I expected. So we'll zoom through this pretty fast, Kate. But the next slide looks at the ROI for traditional telemedicine specialty consults. So often this is, how do you connect with a specialist from your clinic? And then what's in it for me as the clinic that's hosting this visit? Because I'm going to tie up staff time in a clinic room and put a lot of work into making this happen. This is one study coming out of the University of Pittsburgh, and they were looking at 3 of their clinics and saw that with some of the ancillary charges, as well as that originating site fee that they were able to bill, that it did make financial sense for them over the long run to host those visits. Next slide, Kate. Also within EICU, that continuous monitoring of ICU patients, we've seen some good quality outcomes with patient mortality in ICU. But for these community hospitals, perhaps what was more important is they were actually able to see an increase in volume and acuity of their case mix index because providers were more likely to admit patients to the ICU with this backup. Next slide. And so here's some actual numbers of what that looks like in terms of volume. You can see there's a pretty significant increase in volumes between the 2 community hospitals with the implementation of ICU, as providers are more comfortable to admit patients locally than to transfer them to a tertiary facility, and that led to real contribution margin. Next slide. The other area that we've really seen telemedicine support is on that workforce piece again. Can we recruit and retain staff, and what is the ROI on that? And so we look at telemedicine. Sometimes it's helped reduce call burden for physicians. It's helped reduce anxiety for nurses. It's helped make a new advanced practice providers more comfortable to come into a rural practice. And that can help reduce the facility's reliance on locum tenens, which has real cost implications, and really stabilize the workforce within that community. Next slide. We did a study with our own facilities looking at how teleemergency affected recruitment and retention. We had heard lots of stories from CEOs that they said, I had this candidate, I showed them our teleemergency system, and they're like, oh, this has been a big concern of mine. I would love having this as a part of my practice, and even making their decision based on which hospital has that service and which one doesn't. And so we were really surprised to find with our study that almost 81% of providers were saying that they had believed that access to teleemergency would make a difference in their ability to recruit and retain clinicians within their community. Next slide. And so to give you just a little bit of background on emergency, because we have a couple hospitals talking about it today, we provide immediate access to board-certified emergency physicians for rural emergency rooms. And we provide it to nursing staff as well as providers who are working within that community. If they want help with a particular case, or maybe if the provider is not in the room immediately, they can contact the telemedicine network to get help. And we'll help with everything from directing care to calling in support for more help, bringing a specialist into the case, whatever might be needed at that facility. And we'll go on to the next slide. One of the biggest advantages that we've heard from the administrator perspective, I'll talk about quality in a minute, has been kind of helping with their on-call situation. We have hospitals in our network that have 1 or 2 physicians in their group that support their facility and maybe 2 or 3 advanced practice providers. And most of them, when we started, were having their physicians be on call basically every other night in order to meet what they felt like was their EMTALA requirements. So in 2013, CMS came out with clarification for critical access hospitals to understand the difference between their conditions of participation in EMTALA. And the next slide. One of the important findings from this was helping our hospitals realize that they don't have to have a physician on call 24/7, 365 if they really didn't have the physician staff to make that work. So we were seeing lots of physicians that were completely burnt out. They felt that they were on call every other day. They just had no work-life balance and were choosing to leave practice. This clarification allowed the hospital to put advanced practice providers on call as a part of that mix, so they could reduce their call burn to maybe 1 in every 4, and really change their ability to stay within that practice. So next slide. The result of all of this is the opportunity for hospitals really to look at how cost effectively they are staffing their ER. If they're using lots of locum tenens to stretch their call schedule and make it work for their providers. And now they're able to use the backup of teleemergency and use advanced practice providers. They're finding that it can be a real cost benefit to the hospital. Next slide. We'll talk a little bit about quality and outcomes because that's probably the more enjoyable part of this conversation. So next slide. On the specialty consult side, the biggest impact that we've seen is the ability to actually provide care to patients that can't travel within our own network. When we've surveyed our patients, about 30% said that if they didn't have telemedicine, they wouldn't get care. They're not able to leave town. They can't ask a loved one to take, the day off work to take them to the city for care. So it's been a really important way for our especially chronically ill patients to get access to their specialists. And these 2 examples, these health systems are using an e-consult platform, so they're emailing off to the specialist a request for a consult and waiting a day or 2 to see if they get a response back. And both have had great luck. In San Diego, you can see about 65% of the time when they did that e-consult, they were able to deal with it within the primary care office and avoid that secondary visit for the patient. In the second example, they were able to reduce the time to get the specialty opinion to about a day, which resulted in much better care. Next slide. Our next example is with emergency care, and here we know that time is of the essence, and so with that immediate access to a specialist, we've seen that teleemergency can bring a physician into the room faster than if the provider is off-site and at home and trying to come into the ER. That can result in faster care, for example, in this cardiac example, faster door to EKG time, and then faster recognition that this is a STEMI and it does require treatment. So you get TNK started that much quicker and get them transferred maybe to a cath lab if needed that much faster. Those are all really good outcomes for patients. Next slide. On the ICU example, there's a huge study that was done a couple of years ago looking at about 100,000 patients. And their big finding was that ICU telemedicine really resulted again in faster care and better adherence to that evidence base because there's someone always watching to make sure we're checking the boxes on the quality measures. And the result was lower mortality and length of stay. In Avera's own experience, we've seen length of stay in the ICU drop by about half. So maybe from 4 days down to 2 of what was predicted using an acuity adjusted algorithm. And that's 2 days less that the patient's exposed to those healthcare acquired infections and conditions in the ICU. So fewer ventilator acquired pneumonias and DVTs, fewer infections and all kinds of things that get them into the inpatient floor and then eventually out of the hospital that much quicker. And that results in not only results in lower length of stay, which is good for the patients, but also lower hospital mortality because the ICU is always watching, the EIC is always watching and can intervene that much faster if they're seeing a negative trend in the patient's condition. Next slide. Perhaps the most interest for this group is the remote home monitoring. Again, we've seen a lot of good things coming out of this area of technology. This first one is a study on COPD and heart failure patients, and they specifically found a 50% reduction in 30-day readmissions and a long-term reduction in 180-day readmissions as well by using a remote monitoring technology. And this is something like, using a daily weigh-in on a scale, maybe using a peak flow monitor or a pulse oximeter to check in, heart, blood pressure, cough, any of those daily measurements that the nurse can then check in if they're not recording their measures, or if it's higher or lower than expected, and give them a call, see what's going on, and see if we need to order an intervention. The same with the cardiac patients below. There's a correlation between more remote monitoring and higher survival rates among those patients over time. Next slide. One other example that we see coming out of St. Louis is from Mercy Virtual. They have some pretty amazing data coming out of their center with about a 50% reduction in preventable readmissions using their home monitoring team. This is a picture of their hub there. You can see they've got nurses that are checking in on a whole panel of patients and seeing if there's any that are kind of trending out of the set range by their primary care provider, and they can call in and make a change if needed. And finally, next slide, an example from long-term care within a Vera eCare family. 3 years ago, we were awarded a Center for Medicare and Medicaid Innovation Award to provide telemedicine services into long-term care facilities. And we brought a whole geriatric team to the patient's bedside using telemedicine. The result was that we were able to intervene faster when we saw a patient's health status changing, and then really treat them in place. So about 90% of the time, our video visits with the geriatrician and the patient resulted in the patient staying within the facility instead of going to the ER or to the hospital. And that resulted in real savings to Medicare and reduced hospitalizations and ER visits. And perhaps of note for this group is that the sites that were most engaged with telemedicine had a 13% better 30-day readmission rate than their peers. They're performing better on that readmission metric, as well as they had fewer unplanned transfers to the emergency room in the hospital. So not just for the 30-day readmits, but for all hospitalizations and ER uses. All right, next slide. So I'll wrap this up pretty quickly, but where do we go from here? Next slide. Again, I said I'm a big champion for telehealth, but I also know that it's challenging to get it implemented well, and there's some growing pains as you think about implementing a network. Telemedicine is often inefficient, and it causes some duplication. If you're doing a specialty visit, you have to register the patient at 2 clinics. You have to document the care in two EMRs potentially, and bill the patient out of 2 different clinics. So that can be irritating if the workflow is not set up to make that as efficient as possible. Telemedicine adds technology costs and training hurdle. Sometimes it can not work, which adds frustration. So it is different than in-person care in that way. We've talked about the reimbursement and regulatory hurdles. The licensing and credentialing is a paperwork burden that can definitely be a bucket of cold water on a provider that wants to do telemedicine. So it's something to get through. And then perhaps most importantly, really working with clinicians and understanding how it fits within their workflow, how it's going to be accessible and available for them when they need it, and really just flow within their day is important to get that adoption where it needs to be. I think last slide. So where to start? When we look at telemedicine success factors, we think it really comes down to the staffing, how you look at working with your team, either at the bedside or on the remote side, of how they understand that telemedicine is a part of their job, and that it's an expectation, and that they're excited about it is really critical. That includes finding that champion that's really going to push through when it's tough, understand what the magic formula is to make telemedicine work within your setting, and we'll continue to tweak the program to make it fit. Training of your staff is critical so that they're confident with the technology, they're confident in front of their patients, they're confident when we're working with a remote colleague, that they feel good about being on camera and using the various tools. Sometimes that requires retraining and retraining again. And finally, encouraging provider adoption. I think what we found is that telemedicine might take months, if not years, to really engage with a group, especially if they are not excited about it. So giving it time and giving it attention to get it over that hump is really important. So last slide, I still think we see a lot of promise with telemedicine. And I hope after this you kind of got a little bit of taste of what telemedicine can offer and are seeing the promise within your own practice. So I think that's all I've got, Kate.
Thank you so much, Mandy. I hope that you'll accept our virtual applause, if you will. You are just a wealth of knowledge on this topic, and it's so valuable to the Compass 10 network. So we really appreciate you being here and presenting on this today. As a reminder to the audience, Mandy will be available during the Q&A session here in about 10 minutes at the end of the hour. So if you have questions for her, go ahead and start typing those into the chat, or you will be we'll open it up for the audience to unmute their lines at that time as well. Now we'd like to shift to some hospital sharing. As we mentioned at the beginning of the hour, we've got 2 facilities on the line today, and I'd like to first welcome Marcy Schultz. She's joining us today from Hazen, North Dakota. Marcy, thanks for being with us. The floor is yours.
All right, thank you, and good morning to everyone. Again, I'm Marcy Schultz, and I'm the Director of Patient Care at the CoP Medical Center in Hazen. We are a very rural setting with about a service area of about 15,000 people. We're mostly agriculture, mining, and energy industries of the states right there. But the most exciting part that I can tell you guys is we built a brand new facility in April of 2017, and that has definitely changed our workflow and made us rethink how valuable it is. Just a little side note there, I'm just going to say in April 2017, when we built our new facility, our IT was a little bit slow in getting our e-emergency up and running, because it probably wasn't a priority for them, but it became a quick priority for them about 10 days into moving into the facility when our providers were wanting it. It got up and running overnight because they demanded to have it up and running by the next morning. So pretty cool what the power of a provider can do to get that e-emergency when they want it up and running again. We are a 13-bed critical access hospital. We have a swing bed program, general surgery. We're also very blessed to have what is quite unusual across the United States is that our CEO is the CEO for FQHC, so Federally Qualified Health Center, and our critical access hospital. And we also do have emergency services. Our average inpatient census is about 5, and we have telehealth that began in Avera in 2013, and we also do e-pharmacy through CHI Virtual since 2015. Next slide, please. So just to begin, I just want to talk about the equipment needed. Very simple, very easy to do, and Avera helps you through this, or whoever you go through. But we have 2 rooms that have e-emergency in them. We have one in our stroke and cardiac room, and then we have one in our trauma room also. And in each room, there's a TV, there's a camera, and then a speaker that hangs from the ceiling over the patient's bed so all the staff members can be heard. Really something to think about is startup and how that workflow and culture is really going to change for your providers and your nursing staff. And really what we did is we sat down with everybody, talked through the process and the flow, and decided that no matter if it was a cough, cold, trauma, cardiac, we were going to push the button for the first 2 months just to get our staff used to pushing the button and not feel like that it's awkward. And so we did that, and staff became very comfortable, and it was just second nature for them to push the button. As I talked about earlier, we are a rural facility, so a big part of our difficulty is recruiting. It's hard to recruit providers to a rural facility that's 75 miles away from Bismarck, North Dakota, and there's not a whole lot out here. So we had to think outside the box of how we can really recruit, and e-emergency was one of those ways. If you're hiring a student fresh out of med school, it sure is nice for them to know they have backup 24/7, and that's what e-emergency really gives for us. And also we staff with nurse practitioners and PAs Monday through Friday during the day, and so they always have a backup or somebody that they can ask a question to whenever they feel like they need something. A hurdle that you really do need to get over is providers initially felt like someone was watching over their shoulder. They weren't quite sure how they could move forward with that, but they began to appreciate that there's a team in the patient care. A couple examples are one of our nurse practitioners was actually giving a med that probably wasn't appropriate for that patient. Would have been fine, but probably could have gave a better med. And just very nonchalantly, they just suggested another medication and then afterwards explained to them why they suggested that medication. And so actually probably, prevented us from an error for that patient. And the nurse practitioner was very, very thankful. We did make sure that we integrated e-emergency into our orientation. So whenever a provider or a nurse is hired, we teach them how to do e-emergency. We have them push the button, we have them run through it. And then also something else that we do, which I think is very important, is whenever we have a med student come for whether it's 4 weeks or 8 weeks, one part of the orientation for them also is teaching them about e-emergency and just doing a test call for them, because maybe they're thinking about coming to us in the future, and this could be one thing that helps them to feel comfortable in their thought of coming to Sakakawea Medical Center. Looking at the e-emergency aspect and what quality measures that it really helps with, e-emergency can help you with the tertiary calls. So it keeps the provider at the patient's bedside, and e-emergency will make those phone calls for the transport to the patient. They'll do the handoff call for provider to provider, and then their nurse at e-emergency also contacts the nurse at the tertiary facility and lets our nurse really keep their hands on the patient. And I really do feel that that produces positive outcomes. They also review our labs. They have access to our EMR and our PAC system, so they'll review labs. We push our x-rays across through the PAC system. They can review our x-rays, give us a second opinion on that. And the nurses will document for us. So let's just say you're in a trauma situation, we're a small rural facility, we need all hands on that patient. So they're sitting in the background documenting for us and actually giving us little quality indicators, like it's been 5 minutes since you had your last vitals done. Can you get another vitals for me? Or say it's a patient that maybe got caught in barbed wire. Hey, have you thought, that they might need a tetanus shot? They're just throwing little things out at us, making sure that we're not missing anything. They then fax the form to us at the end. We review it, make a few changes if we see anything that we want to update, fax it back to them, and that becomes part of our medical documentation, and we scan that into the patient's medical record. We also receive quality reports on chest pain, sepsis, intubation attempts, and also look at patients that are kept in our facility rather than transferred due to the teamwork between e-emergency and our providers here. So there's many patients that maybe we would have sent out because we're just not sure, but having that board certified medical physician, we can actually look at that patient and say, this patient can stay here safely. A couple of examples that I wanted to share with you are we recently had a sepsis patient about a month ago, and our provider could not get over. I mean, she uses the emergency all the time, but she just could not get over the severity of this patient and how she felt the quality was improved because she stayed right at the bedside with that patient, and the provider was assisting her, but doing all the phone calls for her. So she did not have to leave the bedside once. She was just able to talk to the emergency provider, and they were able to take care of everything. And she really believed that that improved that outcome for that patient. And then I'm just throwing in one example from yesterday. We actually had a patient that come into our facility, and as a rural facility, we're not too excited when it's an OB patient. And this OB patient is calling saying, we're on our way. And we're like, okay. And a little background on that patient, she has 3 children. All 3 children have tested positive for meth. And she is pregnant right now again, and so we knew that this was not going to be good if she delivered here, and so she was dilated to 2. The emergency helped us, and we got her transferred out right away to a facility in Bismarck, and we were very happy to have e-emergency on our side and assisting with that, because that is a very scary situation as a rural facility that does not practice OB. So really, e-emergency has assisted our healthcare facility really become a better healthcare facility and really has improved our quality outcomes. The last thing I just want to touch on is e-pharmacy. We began e-pharmacy, like I said, in 2015, and really we made that. We have a full-time pharmacist, but we wanted it for after hours. Our pharmacist is on vacation to really meet that first dose rule with our inpatients, to make sure that a pharmacist is always reviewing our medications and looking for any discrepancies that are out there. So any telehealth that we can do or services that we can provide for our patient to improve our quality, we are definitely about it and want to be on top of it and one of the first ones to provide it. I do want to offer, and questions at the end definitely, but I do want to offer my phone number. If anybody would have questions, they're welcome to call me at any time. Again, it's Marcy, and my number is 701-426-6948, and I would be happy to answer any questions or assist you with anything that I can help you with. So thank you very much.
Marcy, thank you so much for presenting and sharing your facility story on this implementation. I think it's just so powerful to hear from our colleagues, kind of their barriers and challenges and also their successes in using this type of technology. So well done. Thanks for being here. We're going to switch now and introduce our next guest speaker, Jane Pomeroy. She's here from Stillwater Billings Clinic in Montana. Jane, are you with us?
Yes, I am.
The floor is yours. Thanks for being here.
So I've had the opportunity in the past to work with telemedicine, both in ICU and with home care, but I'm lucky here in Columbus, Montana, to be able to do emergency as well. We are a 10-bed critical access hospital here in rural Montana in the mountains. We're along I-90, so we get a lot of emergency room patients, people from all over, either visitors coming to Yellowstone Park or truckers coming along I-90, as well as our local community that come to our facility. In 2016, we were given an award for the Montana Rural Healthcare Performance Award for Emergency Department Transfer Communications to our facilities in Billings, both the St. V's and the Billings Clinic, where we transferred our patients. We were also given an award from Montana Cardiovascular Health for our stroke recognition and our cardiac recognition. And I believe we received both of these awards because of our use of the emergency, and I'll tell you why in a minute. At our facility, after we have no physician available or provider in-house after 5 p.m. or on weekends, and we're in a mountainous community, so our providers are about 15 minutes away, usually. If there is snow or bad weather, they're about 30 minutes away, and that's how long it can take them to get here. So before we had emergency, a lot of times patients were sitting waiting with us only able to do a few things until they got here. If they came in with chest pain, we could do the EKG, but we couldn't have the EKG read. Now that we have emergency, we're able to go ahead and get the patient started on whatever needs to occur before the physician gets here. So now our EKG is read as soon as we get it. That gives us the opportunity, also the CAT scan to be read if it's a stroke patient. That gives us the opportunity to go ahead and get the thrombolytics started, go ahead and get whatever care needs to be done. And so we have definitely improved our outcomes by being able to have that care done. Our times now for patients coming in for both strokes and MI, being diagnosed, thrombolytics given, and being transferred is about 40 minutes. So we really feel good about that because before that it was over an hour. So this has definitely increased our quality and safety of care. 24/7, we're able to have someone there to help us no matter what it is. The emergency does all of our documentation for us. They arrange transfer while staff can be doing the care that we need to give. This has also helped us with recruitment and retention, as was spoken of before. I've had nurses tell me that they were looking for other jobs before emergency came because they didn't like being here at nighttime, just themselves and another nurse, and having to take care of these patients that came in the emergency room. Now having emergency, they feel much more comfortable. And again, we also did recruit a physician recently right out of school, and he was made up his mind partly because we had emergency as well. He felt like that he would have the support that he needed when he was the physician on call. I have, in my previous lifetimes too, been able to use telemedicine to precept new critical care nurses. So that was something that wasn't brought up, but is something that sometimes can be arranged because it was hard to orient new critical care nurses when you didn't have very many nurses to start with. And so, I was able to work out with a telemedicine, a preceptorship program. With the provider consult, we've been able to really make sure that we have quite high quality ER care. And we have a similar story. I came in one evening where the provider, I walked in and people were running around, and the provider was standing in the hall and almost hyperventilating, and I asked what was going on, and they said that, you know, these providers, they can take care of strokes, they can take care of MIs, they can take care of traumas, but when it comes to a woman in labor, they go into a panic mode. And he was definitely having a hard time thinking that he was going to have to deliver this baby because she was very close to delivery. So we went into the next room, we pushed the button. He got a chance to talk to a provider from eMergency, talked through what he needed to look for and what he needed to do, and he delivered that baby without any trouble, knowing that he had the eMergency there to help him. So it definitely has helped us with our quality in our small emergency room. And that's
Thank
all
you so much, Jane. I really appreciate you sharing your story as well. These are, I think, incredible examples of how telemedicine has played a part in the rural environment. So once again, I know we're nearing the end of the hour, but I do want to, again, thank all of our three presenters for being here today as we enter the Q&A. If you haven't already submitted a question through the open chat, you can do so at this time and we'll moderate those questions. Additionally, if you'd like to speak a question into your phone line, do hit #6 at this time, unmute, and let us know what your question is. Mandy, I think I'll start with you. Earlier in the session, there was a couple of questions that came forward. The question is there a set of codes that can be billed for telehealth services? We use telemedicine for inpatient, skilled care patients, care conferences, and the ED. Is that some of that information mentioned in one of the links you shared, Mandy?
I think it is. I'm gonna share one more link here. It's my my favorite little Medicare packet about what they reimburse for telemedicine. So it has all those requirements that we talked about earlier, as well as the long table of codes that are reimbursed and into what setting. So Medicare is very, like I said, specific. I think looking at your own payers within your payer mix is important. Medicaid is often similar to Medicare, but can be quite a bit different depending on the state. And we've seen that with like Wellmark, they'll maybe copy Medicare to extent and then deviate. And some have just said they'll reimburse anything the same as in person if it can be done well over telemedicine.
Excellent, thank you. And I've copied that link into the public chat, so you should be able to see that there. There may have been one more question about telehealth licensing, licensing, oh my gosh, issues, if you know. And was that in one of the links as well, Mandy?
The issues are, you know, really just around the duplication of paperwork and,
okay.
You know, for nurses, it's, if you're in a compact state, then the nursing licensure compact are fortunate, it's pretty straightforward. Physicians have this new compact that I sent out earlier, and several states have adopted it. Some are having some negotiations with the FBI and their use of their criminal background database, and how they can share that across state lines. But that's moving forward. I think what gets interesting is when you get into other practitioner types like nurse practitioners or counselors, and that there's different state, all kinds of different state requirements that make licensing a fun exercise in understanding regulations. So that can be a little bit more complicated. I don't have a link for that, but certainly happy to answer questions offline if folks have specific questions.
Thank you. I'm going to make a brief pause here for a few seconds. If anyone's on the line with a question, go ahead now. Again, #6 to unmute your line. Well, once again, I do want to thank everyone for their participation in today's event. We do have a few reminders for some upcoming events. The HAI Community of Practice is coming up on Tuesday, November 7th. Also coming up, not too far from now, November 8th is a Wednesday when we're hosting the 2017 Iowa Healthcare Collaborative Annual Conference. Registration is open for that now, and there's links that have been posted to Innovation. If you're having trouble registering, please do contact your improvement advisor, and we'd be happy to assist you. Also, November 9th is the Patient and Family Engagement Community of Practice at 11 o'clock a.m. Wanted to put a quick plug in for something we've got cooking for readmissions in the new year. As we approach the end of 2017, we're planning a refuel readmissions project. This will be a cohort that you can choose to participate in. There's going to be some more project flyers and information coming out about this project in mid-November, so be looking for those. If you do have any questions or suggestions for future content for our COP, we'd love to hear from you, and you can contact me at my email address or phone number listed online. Again, I'd like to thank you all for your participation in today's event. Have a great day.